Hi, this is Professor Tiem, Unit 5, Module 3 of Nursing 1, Explain the Principles in Applying Heat and Cold. Listed here are the 5 sub-competencies for this module. We're going to define key terms related to heat and cold therapy, as well as discuss therapeutic and non-therapeutic reactions, guiding principles when applying heat and cold, the nursing process, and issues surrounding heat and cold therapies related to safety across the lifespan and culture. First, let's review some key terms. Body temperature is the degree of heat maintained by the body and reflects the difference between heat produced and heat lost. Thermoregulation is the process of maintaining a stable internal temperature. The hypothalamus controls this balance and responds to small changes. Core temperature is deep within the body, and it's relatively constant. Rectal temperature is usually obtained and is considered a core temperature. Oral and axillary values are surface temperatures. Surface temperature is the temperature of the surface area of the body, including the skin and subcutaneous layers. What is a normal body temperature? Did 98.6 degrees Fahrenheit go into your head? In fact, normal body temperature can vary depending on a person's age and the method used to measure it. In general, infant and young children tend to have a slightly higher normal temperature, while older adults may run a bit lower. Normal vital signs for various ages show a wide range. Regarding temperature, it has been noted that normal temperature is 95 to 99.9 degrees Fahrenheit, or somewhere in between. Let's break down how our bodies produce heat, transfer heat, as well as regulate heat. First, heat production. The primary source of heat is metabolism, which results from a chemical breakdown process happening inside our cells. Muscle activity also increases heat production, especially during exercise. Shivering is an involuntary muscle contraction that generates heat when the body is cold. And in newborns, non-shivering thermogenesis occurs, which is the metabolism of adipose tissue. Let's talk about heat transfer. Heat always moves from warmer to cooler areas. So here we have radiation, convection, conduction, and evaporation as a means of heat transfer in the body. So we will discuss this further in depth on the next slide. Heat regulation. Vasodilation is a method of heat regulation in the body. This is when the blood vessels widen, the diameter of the blood vessels increase, and blood flow also increases to the skin's surface area. This promotes heat loss in the body. Vasoconstriction is the exact opposite. It's the narrowing of blood vessels to reduce blood flow to the skin, which then conserves heat within the body. Radiation is the transfer of heat from the surface of one object to another without direct contact, such as a person losing heat to a colder room. Convection is the transfer of heat away by air or water currents. An example of promoting heat loss by convection include cool air blowing through an air conditioner on a person or a fan. Also, a cool breeze blowing on a warm day are all good examples. Promoting heat gain by convection include turning up the heater in a room or even giving a patient a warm bed bath. Consider that a warm bed bath does expose the patient's bare skin, and this may involve cooling the patient even more than they are. So consider the best option. Probably turning up the heat would be better in order to warm a patient via convection. Conduction is the transfer of heat from one object to another through direct contact. A good example is placing an ice pack or a chemical cold pack on the skin, which draws heat away from the body into the cooler pack. Another example that may be used throughout the hospital is applying a hypothermia blanket directly on the patient. Because heat moves to the cooler surface, metal surfaces like a radiology table should always be covered with a warm sheet or blanket to prevent an unintended drop in the patient's temperature. Evaporation is heat loss that occurs when liquid changes to vapor from the skin via perspiration or mucous membranes while breathing. This causes cooling. So how do you think humidity may affect evaporation? If it's very humid out, most likely there would be less evaporation. Let's talk about hypo and hyperthermia. Hypothermia is an abnormally low core temperature, typically less than 95 degrees Fahrenheit. Severe hypothermia may be below 86 degrees Fahrenheit. Older adults may run lower, so definitely know the patient's baseline. Some causes of hypothermia include exposure to cold, surgery, drug intoxication, sepsis, or metabolic or nervous system dysfunction. Hyperthermia is a body temperature above normal. Typically, it's around 103 to 106 degrees Fahrenheit. It is not always the same as a fever. A fever, or pyrexia, is greater than 100.4 degrees Fahrenheit. So the difference between hyperthermia and pyrexia is that hyperthermia is a systemic issue that cannot be regulated by the hypothalamus. So in these cases of hypothermia and hyperthermia, these both reflect the body's inability to regulate temperature systemically. Some other terms that you may hear are heat stroke or heat exhaustion. A heat stroke is sometimes referred when the temperature is greater than 106 degrees, while heat exhaustion is above 103 degrees. Some people use these terms interchangeably, but typically we call it hyperthermia. Let's discuss the therapeutic reactions to heat therapy. Physiological effects to heat therapy include vasodilation, that's the first response. So this is when blood vessels dilate. This causes an increased circulation to the area. Heat also increases capillary permeability, which allows gases and fluids to move more easily through tissues. Heat also reduces blood viscosity, making blood less thick and lowering clotting risk. Heat promotes relaxation by decreasing muscle tension and stiffness, which is helpful for muscular pain. It also promotes healing by bringing oxygen and white blood cells to wounds. This does increase oxygen demand in the body, but generally the promotion of healing is a especially positive benefit of heat therapy. It supports the delivery of oxygen as well as nutrients and the removal of waste products from the tissues. So some indications for heat therapy. We use heat for chronic lower back pain, arthritis or muscular pain because it promotes relaxation, wound healing, it helps with menstrual cramps, and it can also be used to help with hypothermia. So for painful injuries with edema or edematous injuries, we'll call them, heat improves circulation and speeds healing. It's most effective after the first 24 to 48 hours following an injury after the acute phase has passed. Deep heat is used to penetrate deep within the tissue, so a warm, moist compress is often the most effective method. Now let's go over the potential non-therapeutic reactions to heat therapy. So what can go wrong if heat is not applied safely? Let's talk about the impact on inflammation and edema. It's important to remember that heat therapy does not reduce inflammation. If we apply heat too soon within the first 24 to 48 hours of an acute injury, it can actually increase bleeding, bruising, and swelling or edema because heat decreases blood clotting time. This is why cold therapy is used first for acute injuries and heat comes later. Next are the non-therapeutic responses and risk of burns. So we are very concerned about burns or tissue damage. So overexposure to heat, such as a heating pad for longer than 45 minutes or setting the temperature too high, poses a serious risk. That goes without saying. This risk does increase with moist heat since water is a better conductor than air. Excessive heat can damage the epithelial cells. So you want to watch for redness. That's more than just the light pink. Light pink is kind of a normal reaction, but dark redness or redness or anything above a light pink color is concerning. Tender skin, blistering, or the patient complains of pain are big red flags. These can signal tissue necrosis or burns. Another possible complication is a systemic effect called hypotension. So when heat is applied to a large area of the body, it can cause extensive vasodilation, which may lead to a drop in blood pressure and a feeling of faintness. So in summary, using heat too soon or for too long can cause increased swelling, burns, tissue damage, or even systemic hypotension. These are all preventable with proper safety measures. Now let's talk about the therapeutic reactions to cold therapy. So how does the body respond to cold and why do we use it? So the physiological effects when cold is applied is vasoconstriction. Initially, the blood vessels will narrow. So this decreases capillary permeability and helps reduce swelling and inflammation. Cold also acts as a form of local anesthesia by numbing the area, which also helps reduce pain. It also slows down cell metabolism, which reduces the tissue's need for oxygen and slows the inflammatory process. Cold increases blood viscosity or thickness, which can help with blood clotting and controlling bleeding. It decreases muscle tension, helping relieve muscle spasms, and it even slows bacterial growth. Because of these effects, cold therapy prevents or limits edema and helps control bleeding, which can also lead to less bruising. So now let's review the indications. So when is cold therapy appropriate? So it's most effective in the acute phase of an injury. The first 24 to 48 hours is when we want to apply cold therapy. Remember that afterwards is when we would want to apply heat therapy. So acute injuries, these includes contusions, fractures, sprains, or strains, and it helps to apply cold therapy to minimize swelling and pain. It's also used for muscular pain and arthritis. It may treat fevers, and it also helps reduce tissue swelling. So this includes engorged breasts in breastfeeding mothers. And cold therapy can also be used to treat hyperthermia and as well as fevers in some cases. Remember also that elevating the extremity also helps. So while applying cold, raising that extremity can further reduce blood flow to the area, which helps decrease the swelling even more. Now let's go over the non-therapeutic reactions to cold therapy. So these are the potential complications of using cold therapy. The first we'll talk about is ischemia or tissue damage. So prolonged or extremely cold applications can lead to insufficient blood flow. So this will cause tissue injury or even necrosis, which is the death of the tissue. Some warning signs that this is happening include a bluish purple appearance, also called mottling of the skin, pale skin or paler, or severe numbness. Now, numbness, slight numbness, is actually a positive response. In some cases, that is what we want, but severe numbness is definitely a concern. These are not normal responses and it should be treated seriously. Another thing to look out for, going back, is watch out for loss of peripheral pulses or loss of capillary refill, as this can indicate signs of severe cold injury. So another complication is increased pain. If a patient reports any pain, burning pain, worsening pain at the site of cold application, this is an immediate red flag and requires immediate attention, and the nurse should assess this area right away. Then there's the rebound phenomenon, and this happens when cold is applied for too long. So after the initial vasoconstriction, then the body kind of adapts to this cold therapy and triggers vasodilation, which kind of reverses the intended effects. So this is what we call a rebound phenomenon, and why we remove cold packs after about 15 to 20 minutes and apply intermittently instead, so that we can prevent tissue injury. Impaired circulation can also be a risk, especially for patients who already have circulatory problems. So cold-induced vasoconstriction could further reduce blood flow, which can make some conditions even worse. Here are the guiding principles for heat and cold therapy. First, always assess the patient's skin before application. This can help identify any pre-existing conditions or skin integrity issues that could increase the risk of injury. We want to also verify the doctor's order to ensure heat and cold therapy is appropriate for the patient's condition and part of their care plan. Determine the patient's ability to tolerate the therapy. So patients with sensory impairments, those who are unconscious, elderly patients, they're at higher risk for injury because they may not sense temperature changes. These are all considered independent nursing functions. So these are actually really important to ensure that these steps are taken. We want to always use a barrier between the hot or the cold source and the skin. So we want to prevent direct contact that could cause burns or any tissue damage. Apply intermittently, such as for 15 minutes to 20 minutes and no longer. Do not apply continuously. Prolonged application beyond that time can cause harm, as discussed earlier. Do not increase the temperature if it no longer feels warm enough, as this could also lead to burns. We do not want to leave the cold or hot therapy in place for extended periods. So 45 minutes, for example, is way too long because this increases the risk of burns and tissue damage. We want to apply heat after the 24 to 48 hour time post-injury for acute injuries. And again, we want to apply cold initially. Applying the heat too soon can increase the swelling and inflammation, so we want to apply that cold first. We want to apply heat or cold therapy to small areas. We want to avoid extensive vasodilation or vasoconstriction, as we know this may alter the blood pressure systemically. Finally, we want to monitor elderly patients closely, as they may not tolerate heat or cold therapy well, and we do know they have thinner subcutaneous tissue. They are much higher at risk for complications. Well, let's get into the fun part, the nursing process of heat and cold therapy. We know that ADPI stands for Assessment, Diagnosis, Plan, implementation or intervention, and E for evaluation. Assessment. So of course, we want to look at the patient's condition. We're going to evaluate the patient's age, elderly versus infants versus younger adults. There will be more of different focuses when we are assessing a patient of various ages. We want to make sure they are conscious. So we're going to assess their consciousness, their cognitive ability, whether or not dementia is in their medical diagnosis, whether that is going to be a concern. Any sensory perception issues like paralysis, numbness, neuropathy, maybe due to diabetes, any skin integrity, so wounds and scars or circulation issues we want to assess closely. Also, we want to assess the patient's skin fully for their color. We kind of want that baseline skin assessment, including the temperature, the sensation, again, the integrity, and any pre-existing edema. These are all important to document. What was their baseline skin assessment prior to any heat or cold therapy? Diagnosis. So some examples of nursing diagnosis include acute pain related to inflammation, maybe risk for impaired skin integrity related to thermal injury, or perhaps ineffective thermoregulation. So planning. First, we want to verify the order, ensure the doctor's order specifies the site, the type, the duration, the temperature, the solution. We want to plan for safety. If there's any barriers, we definitely want to put a barrier between the heat and cold therapy and not place it on the skin directly. We want to plan the time. So intermittent application, we know that a cold pack should be removed after about 15 to 20 minutes, as well as a heat pack. We want to apply it to small areas. We also want to plan heat after 24 to 48 hours after acute injuries. We want to plan the education part, teaching the patient about safe practices and when to remove therapy. These are all part of the planning process. So implementation or intervention, we want to prepare the patient. Perhaps we'll position them comfortably and explain the procedure. We're going to apply the therapy. Again, protective barrier, very important. Never apply directly to the skin. We want to apply it for the prescribed duration, ensuring proper temperature control. Make sure the call light's in reach, especially if it's a more vulnerable patient. We want to position the therapy properly, place it on top and not under any source where it's hard to remove if needed. Evaluation. So the therapeutic effects can be evaluated, and we want to reassess for any reduced pain, hopefully, any decreased swelling, perhaps muscle relaxation occurred. We want to take note of these things. Also, of course, we want to evaluate for non-therapeutic reactions that we talked about. So any adverse changes such as the redness, the blistering, the bluish purple mottling of the skin. So again, slight pinkness, that's okay. Slight numbness initially with cold therapy, that's ideally what we want, but anything more severe is definitely an area for concern. We must document all of our findings. So ask the patient if they are experiencing increased pain or if their pain is relieved. We want to adjust or discontinue any interventions based on these findings. We're going to document, of course, and communicate these things. Safety across the lifespan. So when applying heat or cold therapy, it's important that we remember this general principle. Certain patient populations are at the highest risk for injury because they may have a reduced ability to sense or respond to temperature changes. Let's review each age group. We have the elderly patients. They often have age-related skin changes where their skin may be drier, thinner, less elastic, less subcutaneous fat is present. They may also have reduced sensitivity to pain. Maybe perhaps conditions like dementia or vascular disease or neuropathy may be present. With heat therapy, they may not tolerate well and require close monitoring. With cold injury, they are at a very high risk for injury. With cold therapy, they are at a very high risk for injury. If they are alert, always make sure the call light is within reach so they can report the discomfort right away. Infants and young children may have thinner skin, they're more fragile, they may have an immature thermoregulatory system and limited cognitive ability, which puts them at higher risk for injury from temperature extremes. Pregnant women, they are naturally in a vasodilated state, so extra caution is needed when applying either heat or cold therapy. Patients with impaired skin integrity, such as wounds or pressure ulcers, incisions, open areas, healed burns, or scars, may have reduced sensation and are more vulnerable to injury. Heat or cold may be contraindicated, and you should never apply a cooling device or a heat application directly to an open wound. Always follow the doctor's orders. Patients with impaired circulation, like peripheral vascular disease, require careful monitoring because, as we said, cold therapy can further reduce blood flow. We talked a little bit about the impaired sensory perception. So patients with these issues, such as paralysis, neuropathy, diabetic nerve damage, they may not be able to feel when something's too hot or cold, so they're at higher risk for burns or cold injury. Cold therapy may be contraindicated for these patients. And finally, patients with impaired cognition, of course, unconscious patients, those with dementia or developmental delays, or those that are heavily sedated, they will not be able to recognize extreme temperatures or perhaps will not be able to follow instructions. So orders for heat or cold therapy should be questioned and carefully assessed for safety. Overall, these populations require extra vigilance and close monitoring when applying heat or cold therapy. Finally, let's shift the focus and talk about something that's often overlooked, and it's incredibly important that we discuss culture. So cultural beliefs and traditions can strongly influence how patients perceive and respond to heat and cold therapies. For example, let's look at newborn care. So in many cultures, such as ours, swaddling is normal. Wrapping the baby snugly in cloth to provide warmth and security is what the nurse will teach the patient how to do. In other cultures like Cambodia, babies are not typically swaddled. Instead, parents may place thick blankets and even layers of pillows over the baby, believing that the pressure and layering provide comfort and warmth. This is actually very common practice. This is where nursing sensitivity becomes crucial. So as nurses, we must understand these cultural practices without judgment. We must use therapeutic communication to educate families on safe practices while also respecting their traditions. Now let's talk about traditional medicine. So many cultures, especially in Eastern medicine, view health as a balance between hot and cold, yin and yang. Illness is often thought to come from an imbalance of hot and cold. So even herbal remedies are classified as warming or cooling to help restore this balance within the body. This means that patients may already be using these cultural healing practices, and they may be hesitant to accept modern interventions if they see that this is disrupting their balance. As nurses, it's our job to learn about these diverse cultural beliefs, respect them, and integrate them into our care plans. Culturally sensitive care builds trust, and it also allows us to provide interventions in ways that patients can accept, understand, and feel safe with.